Okay, antipsychotics and anxiolytics, which I'm saying wrong, but okay, we did some of this together. So I said I would add some stuff in here for you, okay? You guys, this is taken from goodtherapy.org. It talks about typical versus atypical, first generation versus second. So when you see typical, you're thinking first generation antipsychotics, and when you're seeing atypical, you're thinking second generation antipsychotics. Atypical also includes third generation, which is a newer class, but we're going to get into a little bit of that. And then you can see, you can read through this stuff right from the PowerPoint. It's posted for you. So what's really cool though here is your first generation, or known as typical antipsychotics. You can click on each one of these to go read about the specific drugs. So if there's something extra that you want on any of these drugs as you're doing things, you can come over here and look at each one of those on Good Therapy. I went through this and they've got great information on here. So each one of these can link you right in. This will be a really good slide, or whatever, the whole slideshow to hang on to come back to later, because we're going to do this again in the future. So what at this point, your first generation antipsychotics, typical antipsychotics, they are dopamine D2 antagonist, okay? They do cause a lot of the EPS side effects that we talked about, and are effective on positive symptoms of schizophrenia, but have little impact on the negative. So remember again the positive versus negative, that the positive are adding to the person. It's not that it's a positive thing, like I'm happy about it. It's things that aren't there at baseline that are now there, like hallucinations, delusions, those different things that we talked about that the patient wouldn't normally have that they did, versus the negative effects, which are things that the patient should normally be doing but now is not. For instance, they were holding a job but now they're not going to work. They were, doing good, had good grooming habits, and now they're not taking care of themselves at all. So remember, positive adds to the person, negative takes away. So with your second generation, or known as atypical antipsychotics, you've got a list here. Again, you can go right into those by clicking on these if you want to learn more on each one. And these are often chosen as the first line of antipsychotics because they treat both positive and negative symptoms, and they produce less of that EPS than the first generations. Their action is blocking dopamine and serotonin receptors. Most of them do cause significant weight gain. That's pretty universal for all of them. But clozaril is one to keep in your mind. This one has a higher chance of causing agranulocytosis than others. So patients that end up starting on clozaril have to have white blood cell counts drawn for the first 6 months of treatment to watch. So oftentimes this one is not chosen as one of the first, second generations to use the way it used to be, because the other ones have a very minimal risk of having agranulocytosis, but clozaril has the highest of the second generations. So then your third generation, I only listed one. It's also known as an atypical. I only listed the Abilify. That's the one that you're going to see the most, and that's the one that we're going to focus on when we get into mental health. But this is a dopamine system stabilizer. So I used to kind of refer to this as a magic drug. It actually goes in and determines, do I need less dopamine or more dopamine, and it can work that way. It's pretty cool. It improves both positive and negative symptoms, and actually it also improves cognitive function. It's the only one that's listed as that, and it produces very little EPS. So at this point, this is what you need to know about that, for that stuff. So we already went through this with the psychosis. We talked about schizophrenia. I went through the positive and the negative symptoms. This little added thing is in here now for you. Antipsychotic agents. So some are listed here. We just went through this. They're going to block the action of dopamine. You have the typical or atypical. Again, typical is the first generation, atypical is second and third generation. You do have these other groups, the phenothiazines and the non-phenothiazines. So you can use those in your drug cards if you would like to. I know for me, and I teach mental health, you're not going to have it that specifically broke down, and I'm also not going to have you do that in the test. However, if you want to have it on there, you feel free to go ahead and do that. if, you know, you may end up needing it at some other point. Haldol, I did keep in here, so that's a first generation antipsychotic that we still seeing used quite a bit. We talked about this a little bit in class the other day. We know that it blocks dopamine, and then we have uses, contraindications, side effects, interactions, all this stuff you can read through. That was the only one I ended up leaving. We know that it can cause the pseudo-Parkinsonism symptoms, so you have that list. So if you know what Parkinson's looks like, you know what pseudo-false Parkinsonism would look like, okay? And so sometimes our antipsychotics can cause that. And then we have acute dystonia, akathisia, and tardive dyskinesias. So we talked about some of these as well in class. These are going to be part of those EPS that we're going to see in the patient. We also talked about neuroleptic malignant syndrome, and we kind of went through that on what could happen. So things that I need to be looking for in this patient, and I need to also know that they started a antipsychotic. And then nursing interventions. So there you go. There's the list of that right there. Again, you've got all kinds of resources, your book, your drug books. You can link into those sites that I gave you when making these drug cards. Make sure you go through your through all of your PowerPoints when you're studying. Remember, we might want to talk to our patients about how it may take 3 to 6 weeks to achieve effectiveness. That's important because if somebody's in the middle of some type of psychosis, we're going to definitely want them to know it's not going to fix overnight and instantly. Again, go through your nursing processes for antipsychotics. The next we are going to talk about is anxiety. We have primary and secondary causes. Okay, that's pretty self-explanatory. Benzodiazepines are showing up again. Okay, so benzodiazepines are used to treat anxiety. Xanax being one of the most prescribed over-the-counter, or not over-the-counter, I am so sorry, most often prescribed from a doctor's office for patients that they stay on the Xanax, and then many times with addiction, I'll end up taking these patients off of it and withdrawing them from the substance. So benzodiazepines, again, you've already probably made this card or have, but it's also going to be used to treat anxiety. So I figured I would pull us in over here for pronunciation because sometimes I need to do this.
Anxiolytic.
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 And I really like how he does it this last time.
Anxiolytic.
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 So there's our pronunciation for that. If you ever need to, YouTube pretty much does every single word out there to pronounce. So our action of our benzodiazepine is going to inhibit GABA by binding to specific benzoreceptors. So it's going to slow down those neurotransmissions of GABA in the brain. So you have your uses, your side effects, interactions, withdrawal. So we have to take them off kind of slower. And then look at those withdrawal symptoms. This is what I'm used to seeing. Tremor, agitation, nervousness, sweating, insomnia, anorexia, muscle cramps, and honestly the list goes on. And seizures can happen with abrupt withdrawal. So we have to teach our patients not to just stop taking if they've been on it. Make sure that you go through your all of your nursing stuff. Here's some interventions for us with the patients that we want to teach them. There's more. We're going to watch for our patients with cheeking. We will discuss this a ton when we deal with the mentally ill because many, many times patients do not end up swallowing their medications, so we definitely have to watch them with that. And then one last anxiolytic is called Buspar. This one is not a benzodiazepine, and we will end up going through this more next term, and I just wanted this to be included in this PowerPoint because it's something that's becoming more used, more frequently used because it does not have the psychological dependency that benzodiazepines will have. So we actually use a lot of this medication in Brighton. You have common side effects listed there, and that there is an interaction with grapefruit juice that can lead to toxicity. So it's important that we teach on that. So I would include Buspar as like a little secondary anxiolytic aside from the other ones, or, you know, obviously you're going to do your benzodiazepines as one, so then you could do this as an anxiolytic by itself. Buspar is a good med to know. So, all right, that's it for this one, and then